All right, it's 7:02, so we'll get started with the first presentation. I was asked to give a brief talk about something that we're doing new here at Baptist, which we're very excited about, called high-intensity focused ultrasound. So it's a new way that we're able to cause an ablation in the brain to treat many types of tremor, but mostly essential tremor, and we'll talk about more of that in a second. So ultrasound, has existed for decades. Well, actual ultrasound waves have existed probably since the beginning of time, but in medical setting, it's existed for decades in both diagnostic and therapeutic ways. Most people are familiar with a fetal ultrasound that you have to use the jelly, and you're able to get a very good image. But there's also therapeutic ultrasound where we can use ultrasonic waves to actually increase the energy and the temperature of tissues and cause ablations. At a high intensity, energy at focal point will increase. And so I tell patients it's kind of like a magnifying glass. If your hand is just under it, it won't hurt. But if you bring that focal point right to the skin, then all of that light is concentrated on a pinpoint. The energy increases and the temperature that increases, and therefore you're able to burn or kill abnormal cells. And so we use the fancy word ablation, but it is burning those cells. It has been used for some time to treat abdominal tumors, such as in the liver or the uterus, but we have come to the point where there was a brain problem. The idea of potentially causing an ablation in the brain existed, the idea existed, but more accurately, it's called the skull problem. How do we get these ultrasonic waves to maintain their energy and accuracy across a three-layered hard surface? And so you can think of kind of cortical bone and then medullary bone and then another layer of cortical bone as these barriers to ultrasonic waves. And then once it gets through, then it's got to travel through brain as well. So it's all these different mediums that a wave has to travel through. And as you know, these different mediums absorb energy, therefore lowering it. And it also refracts energy, bending it, which we'll talk some more about, because obviously we do not want those that focal point to be in the wrong position, causing ablation in the wrong position. I tell people it's kind of like, it's not easy to hear sound through a two-pane window. So if it's a single pane, you can yell out, the waves hit the glass and then travel on, you can actually hear it. But when somebody has a window with air and then another window, it's very difficult to hear on the other side. So we'll talk about high-intensity focused ultrasound a little bit more in terms of everybody that is being considered for that procedure needs to get a special CT scan looking at the density of their skull. 5% of the population about has a skull density that won't allow for these ultrasonic waves to pass. And so every patient makes the same joke, well, I got a dense skull and there's no way and that I'm going to be a candidate. And it really doesn't have to do with the overall density. It's the ratio of how much of that medullary bone they have to cortical bone. Okay, again, to use that two-pane window analogy. And so the other brain problem is, how do we know if the energy that we are introducing is actually changing the temperature? And then if we are changing the temperature, do we know if it's enough to cause an ablation? And then if we are causing an ablation, is it in the right place? And if it's in the right place, is there a beneficial effect? And so that's a lot of ifs when we're talking about making a permanent change in the circuitry of the brain. And so the ultrasound machine that we use, obviously there's various settings that we use to determine the amount of energy being input. And then we use the MRI machine simultaneously while the ultrasound is being delivered to perform MR thermometry, which I wasn't very familiar with prior to starting this. And I'm still kind of blown away with the physics of it, but essentially the MRI that is going at the same time is able to give us a real-time, or at least every 3 seconds, picture of every spot in the brain and what the temperature is at those spots in the brain. And so, as we're introducing the ultrasound, we're getting real-time feedback that yes, we are, increasing the temperature at this one spot, or no, you're actually increasing the temperature at this other spot. And so we're getting this real-time feedback. The analogy that I give to patients is, if you have a gun with a sight on it, the first thing you do is check it out, shoot it, see if what you were aiming at was actually hit. And if it's off by 2 inches to the left, then you have to adjust the sight. And so the MR thermometry allows us to adjust the sight of the target for these ultrasonic waves. Math, physics is able to calculate that a certain temperature for a certain amount of time causes an ablation. And it's just like cooking. If you have a very high temperature, you only need to do it for a very short amount of time. In the case of ultrasound thalamotomy, 57 degrees Celsius for 1 second, we know is an ablation, or 54 degrees for 3 seconds. You can even go lower than that, but you would be delivering ultrasound for maybe minutes at a time. And there is somewhat of a cumulative effect, such that if you don't get a full ablation on the first go round, you can do it again, and those two will add. And then lastly, the neurosurgeon or neurologist can check for the effect by testing the tremor or the lack thereof. So now we have magnetic resonance guided focused ultrasound. We use HIFU, which means high intensity focused ultrasound. It's easier to say than MIRG-FUS, but we get a real-time heat map of that target area. And the MRI allows us a very specific target. So you can see here's a rendering of the thalamus. It's about the size of a small egg. And I tell people it's kind of like a relay station for the brain. If one part of the brain has to communicate with another, one cortex has to communicate with another, most often it's going to somehow go through the thalamus. All roads lead there. Including sensory fibers, memory fibers, motor fibers. And so we're trying to aim for a subset of a subset of this already small target. And that's called the ventralis intermedius. So essential tremor, I call it the perfect HIFU disease. And there's 3 main reasons. Number 1, essential tremor has very few symptoms besides tremor. So, a person with Parkinson's disease, for example, will have difficulty with walking, and they have slow movements and some difficulty with speech. And so people with essential tremor, it's just tremor, and it only really occurs with activity. You may not even notice it at rest. Number 2 is that the treatment is very small, a well-known target in the brain, which I alluded to earlier, the ventralis intermedius of the thalamus. I say well-known because we've known for many decades that an ablation or stimulation in the case of DBS will cause improvement in tremor. So the idea here is not new in terms of causing an ablation. The thing that is new for this technology is how we get there with no incisions. And then the third thing is it has a very testable symptom to look for an immediate effect, and if necessary, make adjustments. And so I guess the example here would be, people have said, well, you could cause an ablation in a circuit that causes some sort of mental illness, depression, for example, but that's hard to test in real time. You could go in and check their mood real quick, but that's kind of an overall gestalt that you would need to, survey and take a long history to see, if it's having an improvement or not. With tremor, it's tremor or no tremor, and you can see it within seconds. So here are 2 pictures. The one on the left is a picture of someone's brain inside. I don't know if you can see it or not, but inside of the ultrasound machine. So see this halo or nimbus? That is the ultrasound machine, which looks like a hemisphere. I tell people it looks like a lady's hair dryer in the salon. And so what is interesting to me about this is that you have to have the target at the focal point of that hemisphere. So imagine a spot at the very center in all directions of that hemisphere, that machine. And so the waves cannot really be bent more than a few millimeters. You know, that adjustment can only be a couple millimeters in any direction. So once you have the patient in position, there's all these calibrations that we do to move the patient's head 1 millimeter to the left, 2 millimeters to the front, to try and line up the target with the focal point. And then the picture that is on the right side is actually a post-operative MRI, which we always get a day after. And you can see here that there is an ablation, this dark area. All right, so this is a T1 image. Oftentimes on the T2, or pretty much always, there is signal around here indicating edema around the spot of the ablation. And we'll talk more about that in a minute. So the test drive. What I think sets apart high intensity focused ultrasound is that it allows us to deliver a lower energy first, enough to raise the temperature and enough to stun these abnormal tremor cells, but not yet causing permanent damage. And this is super important because we're able to raise those cells to, let's say 51 degrees Celsius. Remember that an ablation will occur at 57. And so then I'm constantly going in and out of the room and talking with the patient and testing them out. We have them drinking from a glass, drawing a spiral, writing their name, doing finger to nose. And in the case of tremor dominant Parkinson's disease, it's even easier than that. I just have them hold up their hand to look for the tremor. And so if we are in the right spot, then their tremor will be better, okay, just by stunning those cells. But we haven't made any permanent changes yet. And I also check to see if they have any abnormal or negative side effects that would indicate that we are stimulating, in this case, or stunning the wrong cells. And so, for example, if they say, oh, I have some tingling in my face or my hand, any paresthesias, that would indicate we're about 2 millimeters too far back, all right, in the VPL, or the VP of the thalamus. So that means that we're in the wrong spot, but really by 2 millimeters. And that's okay, because we haven't made any permanent changes yet. So we move our target forward until we get good effect on the tremor with no side effects. Interestingly, if you're in the right spot, people will often say that while the ultrasound is being delivered, they feel like they are falling backwards, like doing a backflip, which can be very disconcerting. At least if you tell the patient about it, they don't get scared about it, but it doesn't make it any more pleasant. We do give anti-nausea medicine to every patient now in anticipation of that sensation, which can cause nausea. And so I just described, if there's no improvement, we may need to move the target. If there is good improvement, then we go back out to the machine, increase the settings, increase the energy, and cause a permanent ablation. And then pretty much done. So the advantages, it's non-invasive. That's super attractive to patients. Since we've started doing this, I for completeness sake, present all options and alternatives to patients with essential tremor, including deep brain stimulation. But it's a hard sell to have somebody, say, oh, we're going to do this awake brain surgery, do a burr hole, et cetera, when they know that this exists. And the other thing is, if there was a huge difference in effectiveness, then maybe you could make that argument. But we've been able to find that it's super effective. There's no hardware to worry about. So people with DBS, they're always worried about if I get dental cleaning, am I going to get an infection of the hardware? Do I have to get my battery replaced every few years? Those types of things. And then this test drivability, I think that is a huge advantage. So one way to cause an ablation, it has in the past has been ionizing radiation, stereotactic radiosurgery, but you can't see the effect right away. And if you're in the wrong spot, then it's too late. It's already been done. So it kind of merges the best of both worlds in that sense. the drawbacks. So I start with this in clinic. I say, we have to shave your head. So I haven't had anybody back out because of that, but some are a little bit surprised by that. And the reason for that is because hair follicles tend to hold on to air bubbles, and air bubbles, when exposed to high intensity focused ultrasound, will raise temperature and maybe turn into steam. So we don't want one of those cartoon things where the steam is coming out of the ears. And so the other thing is, I would say it's not an easy alternative to the deep brain stimulation procedure. Some people say, well, I don't have to go through brain surgery, I'll just go through this. I try to make sure that they're aware that that's not really the case. We have gotten very efficient at it. It takes about an hour on the table. But the head ring application can be painful. We use local anesthetic, but that's not very pleasant. And then they have to be flat on their back for the duration of the procedure. Whereas with deep brain stimulation, we're in like a reclined position, they're in a more comfortable actual situation. And then during the procedure, people will say that their head feels warm but not uncomfortable. And then we talked about that feeling of falling backwards or nausea that people can get. And so some people, interestingly will say, oh, that was cool. That reminded me of the 1960s or whatever. But other people say, get me out of this thing. I cannot tolerate it for another 30 seconds or another sonication. That's what these ultrasound deliveries are called. And then the other drawback is it's not modifiable after the treatment. So the beauty of deep brain stimulation, for example, is that you can turn the settings up or down. You can even change the direction of the stimulation with certain technologies. So, as their tremor progresses, which it will with time, it's a degenerative disease, you can change the settings to match their tremor and still get tremor relief. And then the other drawback, which is, thank goodness, usually temporary, are all these side effects of numbness in the face or hand. The biggest one would be difficulty with balance and walking. And so I tell people that if we're causing an ablation about the size of the tip of a cigarette, and you put a cigarette out on your skin, it would be about 8 millimeters wide. But if you looked at that same burn the next day, of course, you would have the burn plus all this redness and edema surrounding it. And the same thing happens in the brain. That energy spreads, and there is swelling or edema in those parts of the brain, in the thalamus, no less. And so guess what? Those parts do other things, such as sensation, difficulty walking. And as we've gathered more and more experience, I'm less and less surprised by any complaint that the patient has. And one that we've seen is kind of some slowness of speech. The good news is, as that edema recedes or goes away, those symptoms go away, and the only thing they're left with is tremor suppression at the site of the ablation. And then lastly, it can only be done on one side. And so when they have done it on both sides simultaneously in other countries, it's not FDA approved here. Those balance problems that I just mentioned are, compounded to the point of not being able to walk. So that was not FDA approved. Now, there is a trial that has already been completed. The data has been submitted to FDA, where if you separate the two sides by 6 months, give one side a chance to kind of heal up, and then do the other side, that those negative consequences can be mitigated. And so almost every patient, their first question is, when can we do the other side? Which is a testament to how satisfied they are with the treatment. But also, I say, I'll put you on a waiting list, and as soon as the FDA approves it, we'll maybe proceed. So the shaved head, some people don't want to look like this. Final points. Tremor is not just normal aging. I was speaking with our guest yesterday, who's a tremor expert, and I think that the public needs to be educated. Physicians, yes. Neurologists, yes. But the public needs to be educated. The tremor is not just, oh, I'm getting older, and so they should seek some sort of treatment because it exists. Essential tremor can be treated first with medication, especially milder essential tremors, and the two main medications are primidone and propranolol. But high intensity focused ultrasound is a new, safe, and very effective treatment for tremor. I'm excited for where this could go. It's more recently used for Parkinson's disease, particularly tremor dominant Parkinson's disease. And research is being conducted on, we talked about second side tremor, as well as other movement disorders and psychiatric conditions. You know, the whole idea is that you're disrupting a brain circuit. And in the cases of these diseases, there's some abnormality of the brain circuit, and we're stopping that. And so I think that there is a lot of potential for this technology, and it's very well tolerated. I forgot to mention, you know, sometimes somebody might be interested in deep brain stimulation, but you know, they're 85 years old, they have medical problems. This is a safer alternative, in my opinion. And that's what I have. Thank you very much.
Hey, Justin, Sharif Sedani from Radiology.
Hi, Sharif.
Great talk. Thank you very much. Two quick questions. When the sonographic waves are they delivered like throughout the skull or just from one entry point?
No, so there are up to 1,000 transducers based on the surface area that we're able to expose. You know, we'll get anywhere from 800 to 950 of them are usable. So the ultrasound cannot reliably go through a sinus, for example. So we have to shut those down. Or if there are calcifications up near the top of the skull, you have to shut those off as well. So basically you start with 1,000 and then you have to shut off a certain amount, but they're coming from all directions at this one focal point.
And the system itself adjusts for the different like density and hyperostosis of the bone from different directions.
Yes. So, you know, I don't feign to understand all parts of it. I'm just a neurosurgeon, but the physicists have figured out how to develop a system that is not only delivering ultrasound, but also listening for acoustic interference and then being able to somehow, you know, retroactively calculate, well, if it's quote unquote noisy ultrasound on this side, then there must be something wrong over here, and turn those off or modulate the amount of energy coming from this side. And so, yeah, it accounts for all of that.
And another question is, if you do this surgery, DBS is no longer an option if the patient deteriorates, correct?
If this does not work?
Yes.
Well, no, because if we do cause an ablation, like we actually kill those cells and then they don't get better, number one, I'd be worried about my diagnosis. And then number two, the cells that we would target with deep brain stimulation are gone, or there's an ablation there at least, so that you wouldn't get a reliable stimulation. I have had people who say, well, if I can't get the second side with the ablation, can I get DBS on the other side? Yeah, the answer is yes, but you couldn't go in the other direction. You can't get DBS on one side and then get the ablation on the other, because now you have this hardware in your brain that we can't use the ultrasound or the MRI to do it.
Thank you. Fantastic talk. Thank you.
Thank you.
Justin,
Yes.
This is Kevin. Great talk, great overview on everything. Since you just touched that subject with doing DBS on the other side after you do, you know, an ablation on the other one, do they have a higher incidence of, you know, difficulty with balance, or, and from what I understand, sometimes cognitive issues? Do they have an increased incidence of that, although not as great as bilateral thalanotomies?
Yeah, there's not a lot of research on it. I don't have personal experience with it yet, because even the people who are, you know, diehard want the second half of their body treated are more willing to wait for the FDA approval, which could be, you know, 5 years from now, than to get the DBS. But you can do DBS on two sides, and but yeah, the difficulty with the balance and cognitive issues, those, you know, those can be magnified definitely more than if you just got a single side.
Yeah, great, thank you.
Justin, hi, it's Ron Tolchin. Great talk. I don't know if you mentioned it, but in terms of negative or side effects, have you seen anything personally?
Yes, I mean, not permanent, that's the good news. But I think the most common is that they feel like they got off of a cruise ship for about 3 days to 2 weeks. By the time I see them back in clinic, they say, yeah, you know, that wasn't really fun, but it went away.
Okay.
Other people have reported some paresthesias. I've had probably 4 out of 71 people say that they had some difficulty speaking. Not they can still communicate, but it was like slow words like this. And then I even had a guy who had basically hemiparesis. That was like probably the second patient that we had, which, you know, I'm thinking, oh my God, you know, but the more I thought about it, he did not have hemiparesis on the day of the procedure, which means we could not have burned those cells. It showed up 24, 48 hours later, which means it was from edema. And in fact, when we get the MRI, almost everybody has edema extending into the internal capsule, which is all the motor fibers coming down from the motor cortex.
Right.
So I'm actually surprised that more people don't have weakness or difficulty with coordination, but they don't. But you know, lots of people have edema going into the internal capsule, across the internal capsule, and like if you see a brain MRI like that, you know, outside of this situation, you would say, well, I would expect this person to be weak. So.
And then it subsides. The edema subsides. Have you done some follow-ups?
Yeah, well, not on purpose. So some of these people, for various other reasons, get MRIs of their brain. You know, they develop some other thing. They hit their head and they have a subdural hematoma or whatever. The ablation, the edema goes away completely. The ablation itself can almost look like it's disappearing. And I don't have a great explanation for that, except that I think that the brain itself is kind of just filling in the spot. Obviously, those cells are gone. They're not growing back. But, you know, kind of the whatever back pressure from the brain, because it's right in the center, is kind of filling in the spot.
Thank you.
I think you're entirely right, Justin, because it's sort of like sometimes tiny lacunar infarcts that somebody has, you know, clearly seen on diffusion weighted MRI, you know, months or years later, you look and you're like, they had an infarct somewhere, and it's, you know, totally seemingly vanishes. We know it's there, but it's like slit-like and you can't even make it out anymore.
All right, there's one question from somebody who's logged in as observer.
That's me. Sorry, I was a board examiner last week and I haven't changed my name yet.
Okay. All right, thanks, Ron. Justin, thanks for that presentation about great technology. And Justin has done over 70 cases since September of 2021, and will have a very large experience to analyze volumetrically with follow-up imaging sets, as well as the clinical information. So very exciting. Next up is Dalia Lorenzo from First Choice Neurology. Dalia.
Okay, hold on a second. I'll share my screen. Oh, here we go. Okay, I'm trying to share the screen here. Hang on a second. Okay, can everyone see that?
Yes.
Okay,
Yep.
Here we go. So this is a case of a patient that I saw through clinic. He's a 65-year-old man, a physician and a professor, and who came to me with a 5-year history of progressive forgetfulness he had been having. For a few months before visiting, he had started to have auditory and actual formed visual hallucinations, and also the sensation of insects, crawling. And he also reported that he had episodes of clouding of consciousness. He would describe these as he felt like he was in a dream. He could function, he could drive, he could do everything, but he just felt a little derealized. The patient did have sleep apnea, but was very compliant with his CPAP, wasn't really describing sleepiness. He also had significant depression, but was taking Lexapro and actually had been improving. He had numerous other complaints, including imbalance. He had a few falls, some numbness of the left eye, urinary urgency. And so his examination, I did a Montreal cognitive assessment on him, which was abnormal especially for physician 25. He did have an underlying diagnosis of some mild dyslexia. He had increased reflexes at the knees with a beta-clonus at the ankle. And he had some diminished sensation in the left leg, which was really mostly in a dermatomal distribution for the L4-5 dermatome. Pertinent negatives in terms of the history, he had he had very smooth ocular pursuit, so no saccadic pursuit, normal full eye movements, including up gaze. He could walk normally. There was no, signs for Parkinsonism, no ataxia. The exam was otherwise normal. So here is, I'm just showing his Montreal cognitive assessment here. See if I can, and just to show you some of the things he made an error with. He forgot the number 1 here on the clock. He made an error on calculations. He forgot a word here in the repetition. And this is the fluency test where, how many words can you produce that start with the letter F in 1 minute? And, it was normal, it's more than 11, but for a physician, this is very low. So, and then he did miss 3 of the 5 items. So his overall score was 25, abnormal. So initially then the impression was mild cognitive impairment with psychosis, some changes in the level of awareness and depression. So the thinking was, dementia picture or pseudo dementia, I'm sorry, the possibility of limbic encephalitis, of course, with a psychosis. There was not really the Parkinsonism or ataxia, but frontotemporal dementia is also a possibility. I had a lower suspicion for seizure. So I ordered some labs, including the autoimmune encephalitis panel. We did an MRI of the brain with contrast. Because of the hyperreflexia he had, I also added an MRI of the thoracic spine, some labs related to that. I started him on some modafinil, thinking maybe he needed it for hypersomnia despite using CPAP. He did not ever report any cataplexy or anything like that. And then, he had findings, and he already had an MRI of the lumbar spine that showed a compressed nerve, so radiculopathy. So the initial testing that came back, he had a borderline elevated CRP, but his SED rate was normal. Negative tests include ANA, RPR, the ammonia. Later on, we checked an ANCA, that was also negative. His B12 was in an adequate range. Fully, the TSH was normal at that point. RPR, HIV, AM cortisol was okay. I checked his copper for the hyperreflexia, that was okay. We did an MRI of the brain, which showed a pituitary adenoma and some microvascular changes, and an EEG, which here's a picture of it. It was very normal, good background, 10 hertz. We also had the MRI of the thoracic spine. It didn't show anything abnormal, no compression, no signal abnormality. And the MRI of the lumbar spine, as I mentioned, showed a disc compressing the L5 nerve root on the left. And CSF, well, he didn't want to have that done. I was never able to get CSF on him. But so here is MRI. Here's just just one cut showing some of the microvascular changes that were described. There were several of these. Okay, and then here, this is just a cut showing the pituitary lesion. Here's another image of it. It's sizable, as you can see. This one's with contrast. So we actually got more testing back over the following few weeks, and he was found to have positive voltage-gated calcium channel antibody. He was also found to have positive anti-glial neuronal antibody also known as SOX1 antibody, and this was significantly positive. It was detected on Western blot, not the actual immunofixation, and it didn't seem to fluoresce in any of the neuronal tissues. But it was significantly positive. Negatives, the rest of the autoimmune panel, autoimmune encephalitis panel really came back negative. This voltage gated calcium is the type N. So he actually, his antibodies appear, the calcium channel antibodies were the PQ type. So, anyways, he comes back. His psychiatrist has increased his antidepressant. It's improved his mood. He's doing better that way, but he's still having the cognitive issues, really having trouble at work, hallucinosis. So the working diagnosis at that point was an autoimmune encephalopathy with anti-glial neuronal antibodies. He was positive for this voltage-gated calcium channel, but didn't really have the usual syndrome of Lambert-Eaton myasthenic syndrome symptoms. And he has this pituitary lesion and this radiculopathy. So just as a reminder, just this for information, the anti-glial neuronal antibody paraneoplastic syndrome is associated with small cell lung carcinoma. It's an intracellular antigen problem, and it can present with paraneoplastic cerebellar degeneration, which he had no ataxia, no signs of this, limbic encephalitis, which is a possibility here, neuropathy, which can be sensory or motor sensory, and it can also present with a Lambert-Eaton myasthenic syndrome. And then, of course, the voltage-gated calcium channel paraneoplastic syndromes. These channels are large protein channels that are present in 95% of the neuromuscular junctions, and obviously play a role in the release of acetylcholine. So they present with Lambert-Eaton myasthenic syndrome, not usually limbic encephalitis. Okay, I do have to say that in reviewing this, there was one report in the literature for rapid dementia with the N type of voltage-gated calcium channel, but our patient is actually PQ type. So usually Lambert-Eaton is diagnosed when there's a high pretest probability of it, where you're finding symptoms and signs for myasthenia, and the diagnosis is doing electrophysiology studies and including the antibody. It's an important syndrome to detect because obviously 50% of Lambert-Eaton patients develop malignancy, usually a small cell lung cancer. So anyways, I referred him to the neuro-oncology clinic, and we decided to get more testing. I wanted to get an MRI dedicated to the cella to look at that pituitary lesion. We got the CT of the chest, the abdomen. We're going to get the pituitary hormones. And then he was really not doing well. So decided to admit him and to get all these things done more quickly and to give him a trial of IVIG and Solumedrol. So the CT of the chest really didn't, and abdomen really didn't show much. Some peribronchial thickening. There were no nodules, no enlarged lymph nodes. He had a cyst in the kidney. So he goes into the hospital and the hormones are drawn, but they're not, unfortunately, some of the labs were messed up. So we got some labs before, Solumedrol and IVIG, FSH, TSH, which are okay. But then the other labs were done after his first dose of IVIG Solumedrol. His TSH now has gone down, but his thyroid functions are still normal. Cortisol is elevated with the Solumedrol, and the prolactin was okay. And so we went ahead and had the MRI of the cella, which, I'm just showing different cuts of it, as you can see here. The lesion that he has that is extending into the sphenoid sinus. It was 1.2 centimeters by 1.6. It was deviating the pituitary stalk, but it wasn't really causing any pressure onto the chiasm, to the optic chiasm. And he never had any visual field defects or anything. There's another picture of it. And this is pretty much the same picture we saw earlier. So, okay. So I start giving him the IVIG and the Solumedrol, his first dose. he has a little bit of a headache. On the second dose, more headache. I walk in to round on him when he's receiving his third dose, and he just had this severe headache. He was in the recliner, his partner was on the sofa, and he was just clutching his head and just complaining of a very, very severe headache. He had continuous vomiting. We had to even give him Ativan. He was so distressed. So obviously I ordered some additional, imaging to see what's going on here. So I did a CT brain, CTA. Here's the CT brain, during the headache. I mean, the lesion's still there. This one was read as now having a little bit of mass effect onto the optic chiasm. Here's the coronal. So anyways, his headache subsides, but of course he becomes very, very distressed. He's very distressed, so he discontinues any more. He doesn't want to receive any more IVIG or Solumedrol, because obviously he equates that with it. So then he leaves hospital. He follows up in neuro-oncology and gets the rest of the testing. He has the repetitive nerve stimulation to look for Lambert-Eaton myasthenic syndrome, and this is negative, as I would expect, really based on the pretest probability. He had some mild carpal tunnel that was seen. He gets the PET scan from the skull base down, which is negative. There wasn't any uptake either at the cella, and the plan was to repeat the MRI of the brain and PET scan at a 3-month interval. So here's the 3-month follow-up MRI, and lo and behold, the pituitary lesion is gone. So the tumor is missing, and now we have an empty cella. So the pituitary is flat. Okay, so he comes back to neurology clinic, and he does report that with the IVIG and Solumedrol for, afterwards, he did feel better. He was able to function better at work. He wasn't having the hallucinosis. He felt more oriented. He hadn't had any more episodes of headache. And so he did improve. So the diagnosis that we came up with was that he had hypothesitis, and he has a paraneoplastic anti-glial neuronal antibody encephalitis that remains under surveillance. So just to kind of review, hypothesitis is an it's just an umbrella term. It covers different inflammatory disorders that can affect the pituitary gland. There can be primary and secondary causes of hypothesitis. The primary causes can include things like lymphocytic hypothesitis, granulomatous. Necrotizing is very rare. Secondary causes, a lot of them. Infection, obviously, rupture of Rathke cleft cyst, different tumors, germinomas, craniopharyngioma, other neoplasms in older people. You have to worry about lymphoma. Drugs, including the checkpoint inhibitor drugs that are increasingly used. And then obviously a lot of the inflammatory autoimmune conditions, Sjogren's, lupus, also diabetes, thyroid disease, sarcoid, vasculitis, histiocytosis, IgG4 disease, and other autoimmune. More recently, there have been discoveries of a paraneoplastic syndrome, which can cause hypothesitis, and it's due to antibodies that are provoked by expression in thymomas of the pituitary antibodies, and those patients will present with hypothesitis as their paraneoplastic syndrome. So the presentation for hypothesitis is, they present with symptoms or signs of pituitary deficiency. 50% will have headache. And of course, if they have an enlarging mass, they can have visual symptoms, visual field cuts from the mass effect. The MRI will show a thickened pituitary stalk. The gland is enlarged, like what we saw. Usually they have homogeneous and intense contrast uptake, which really wasn't described in our case. And because it's an acute situation, the sella is not usually eroded. There can be a dural tail from dural inflammation. And then, you know, there's this wonderful paper, and I reproduce it here for you guys, that goes over the diagnostic algorithm and treatments for hypothesitis. You know, it's an involved thing that we do not have time to go over here, but essentially glucocorticoids are used to treat the cases of hypothesitis, and he was already on the Solumedrol. So, oops. So, all right. You know, so this article here is wonderful. Let me leave it up so in case anyone's interested in looking into that. So that's all I have. Is if anyone has any questions.
Oh, no, actually, one of the first papers that I ever did when I was a resident was on lymphocytic adenohypothesis in males, which is unusual because it's usually in women.
Right.
This is another example of a male, but a very interesting algorithm here for the workup of this condition. Very detailed.
Dalia, this is Sharif. So fantastic case. I don't think, you know, from a radiology perspective, hypothesitis would have made it my differential in this case. But from the few images you showed, this guy had frontal atrophy for somebody this young.
Yes, agreed. That's one thing that I had. That's why I included frontal temporal dementia, because you know, in the initial, you know, once I had seen his image, I was like, okay, he does. And he was reported to have some personality issues, but I think those were more chronic. So you know, it's still in the differential. We'll have to see. The fact that he improved with the treatment with the IVIG and the Solumedrol maybe speaks a little bit against that, but that still remains a possibility. We'll see. Time will tell. I mean, I really didn't find any of the other exam findings that I would expect.
Great, thank you.
Hey, Dalia, this is Kevin. Again, great case. And actually, as you know, I was familiar with this case because I read the follow-up MRI. I'm not even sure if I read the original MRI, but, you know, looking back on it, it's very unusual for hypothesitis because it was very focal and almost like well circumscribed, rather than hypothesitis. It's usually diffuse, has thickened stalk and everything. So not only was the follow-up MRI like a month later, you know, the tumor, quote unquote, was totally gone. But even when the patient had like their PET MRI, which was, I don't know, a couple of weeks after, it was also gone. So whatever steroids or IVIG, I mean, it made a remarkable disappearance in such a short period of time. And again, even looking back on it, it's not one I would have included hypothesitis on it.
Yeah, that's why I was like, okay, missing tumor.
Yeah, no, it's a fantastic case. And how is the guy doing now?
Well, you know what? I'm having a little trouble getting him back into clinic, you know, but he's been doing okay. His follow-up is going to be, you know, monitoring for to see if malignancy shows up. But we've been contacting him to return to clinic. I'm a little worried about him develop the hypopituitarism. So, you know, I also want him to follow up with the endocrinologist. So yeah, we're working on getting him back into clinic.
Thank you, Dalia.
All right, any other questions from anybody? If not, we'll take a few minute break for people to catch up on coffee, etc., and then come back at 8 a.m. sharp. Okay, so this morning we're delighted to have Dr. Diego Torres, who's professor, vice chair for education in the Department of Neurologic Sciences at the University of Nebraska Medical Center. He's the chief of movement disorders, the program director for the Movement Disorders Fellowship, and the director of clinical neurology education. And so I'm going to just get Dr. Torres set up here. And then we will start. All right, do you see that full screen then? The slide full screen? If somebody could reply back verbally, that would be helpful.
They're actually seeing the presenter's mode.
Okay. Have a look there. Okay. Thank you very much. Here's Dr. Torres.
All right, thank you so much, Dr. Madermo. It's a pleasure to be here, an honor to be here to talk about a topic that I'm extremely passionate about. So we're gonna talk about Parkinson's disease and what's the state of the art care. What do we mean by, geez, if my mother had Parkinson's disease, what do we have to do to get the best possible care set up for for my mom, for my dad, for my family member. That's the way I think all of us want to be thinking about caring for each of the diseases that we care for. So these are my disclosures. I have multiple consulting relationships and research, the educational grants from multiple companies. So movement disorders in the general community are highly prevalent, and but they are substantially under-recognized and therefore under-treated. The prevalence for only the common categories of movement disorders is 28% in the general population. So they are extremely common, but as you can see, if that number shocked you of 28% prevalence, it means that you agree with me that they are extremely under-recognized. And therefore, what that means is that our patients are suffering without any need. And our patients deserve best possible care. Movement disorders are the third worst neurological disease in terms of quality of life after pain and spinal disease. So this is critical. We need to make the diagnosis so that we can help them. And that reminds me, we are here to cure sometimes, to relieve often, and to comfort always. So help me think today, how do we cure Parkinson's disease? How can we best care for patients with Parkinson's disease? And there are many considerations in healthcare when we're thinking about those questions. It all starts with the patient and the caregiver and the disease, but then we have to think about the healthcare system and research and medical and education, medical and patient education and costs and payers and many factors. So today I'm gonna try to tackle some of these questions. So the first one is, what do we really mean by Parkinson's disease today, right? Because that concept has been changing over time. The next is, how do we diagnose Parkinson's disease at this point? And why do we say that Parkinson's care must be comprehensive and multidisciplinary? What are the most common innovations in Parkinson's disease care? And lastly, what can we do right here, right now, to enhance the Parkinson's patient experience? So what do we really mean by Parkinson's disease? Well, this is the way, people used to think about Parkinson's disease. And this is the way I think now about Parkinson's disease. This is a boxing class for our Parkinson patients. This is what we get now, a bunch of people exercising, being active, trying to do the best they can to improve their disease. So, the face of Parkinson's has changed dramatically. We used to think of very old people. Parkinson's disease affects patients that are extremely young as well. So we need to think about it in a different way as well. Parkinson's disease is extremely common. 1 to 2% of the population is a neurodegenerative disease that is widespread and produces a myriad of motor and non-motor symptoms. And it has multiple diagnostic criteria, but it all starts with the presence of bradykinesia plus either resting tremor or rigidity. And bradykinesia, which is basically slowness of movement, is required for the presence of this disease. Dr. Louis described what we now call the Lewy bodies, which are these cytoplasmic inclusions in Parkinson's disease, which primary structural component is an abnormal protein called alpha-synuclein. And the accumulation of this alpha-synuclein inside the Lewy bodies seems to be essential in the disease. And as you can see here, this round cytoplasmic inclusion is the Lewy body in the substantia nigra, which is typical of Parkinson's disease. And when that occurs in the cerebral cortex, then we tend to have Lewy body dementias as well. So these Lewy body diseases, the distribution started to be described, how that distribution would happen in 1984. And then Brack and Brack more recently in 2002 described this ascending distribution of the alpha-synuclein and the Lewy bodies in Parkinson's, meaning that the disease is spreading from a particular location into the rest of the brain, and implications for our pathophysiological understanding of the disease can be drawn from this for sure. The common motor symptoms in Parkinson's disease are resting tremor, bradykinesia, and rigidity and discussed, but then later on the patients can develop balance issues and falls, gait disturbance, including freezing, and motor fluctuations. And I truly believe that one of the biggest problems in Parkinson's disease are the non-motor symptoms, and they are frequently unrecognized, not only by physicians, but also by the patients, because they don't think that the non-motor symptoms are, related to the disease, and therefore they are untreated. And these are major determinants in the quality of life, from the disease. So what are these non-motor symptoms in Parkinson's disease? Well, the first is the neuropsychological features. Some patients can develop dementia, some can develop psychosis, meaning hallucinations, which tends to be medication induced. It's a side effect usually from the drugs that we use. Depression, anxiety, impulse control disorder, which is a common side effect from the drugs that we use in Parkinson's disease. And then sleep disorders are common in Parkinsonism, insomnia, restless leg syndrome, REM sleep behavior disorder, and excessive sleepiness during the day. Dysautonomia is almost universal in patients with Parkinson's disease: constipation, dysphagia, drooling, bladder dysfunction, orthostatic hypotension, and sexual dysfunction. And as you can see, all of these things can induce extreme changes in the quality of life of the patients. So, and then lastly, are sensory issues that we need to be considering as well. What causes Parkinson's disease? Well, at this point, we're thinking that Parkinson's, it's not just the one disease, it's multiple diseases. It has been associated with multiple gene mutations. Over 15 genes have been associated with Parkinson's. I think more than 20 genes by now. And then environmental factors, pesticides, solvents, occupational exposures, rural exposure, now urban exposure, so go figure that one, if you have more than 14 years of education, that increases your risk of having Parkinson's disease. So, you know, multiple environmental factors, drinking more milk in comparison with the general population. I mean, it's just so many factors that have been linked with this disease. None of them truly causal, just an association with the disease. Now, Gba gene mutations, the gene that encodes for glucose cerebrosidase and the one that has been associated with Gaucher, those mutations are the most common genetic risk factor for Parkinson's disease. And both biallelic and single mutation mutations have been associated with the disease. And as you can see in this slide, it also has been associated with Lewy body dementia, REM sleep behavior disorders, and you know, can be seen in many different communities and ancestries. Probably one of the most important messages that I can share with one of my patients is that physical activity prolongs the life in Parkinson's disease. I truly believe this. I believe that exercise can make a huge difference in their quality of life long term. And you know, this study from Korea in more than 10,000 patients showed that physical activity, regardless of intensity, is associated with reduced all-cause mortality among patients with Parkinson's disease. So this is an important thing that we need to continue to remind all of our patients about. So in summary for this question, what do we really mean by Parkinson's disease? This is a common neurodegenerative disease, might be the second most common neurodegenerative disorder. Both motor and non-motor symptoms are affecting quality of life, and therefore we need to address both. It is associated with accumulation of alpha-synuclein in Lewy bodies, and it's a syndrome with many diseases with genetic and environmental risk factors. The next question that we wanted to think about today is, how do we diagnose Parkinson's today? And I think about these three questions first. Does the patient have Parkinsonism? Which type of Parkinsonism? And is this genetic or not? So, and proper management and quality of life of the patient depends on these questions. So we must address them with our patients for sure. So, you know, we have said tremor, rigidity, and slowness, bradykinesia, make up the diagnosis of Parkinsonism. And then, you know, Parkinsonism can be either primary or secondary. When you have primary, then we divide that between idiopathic Parkinson's disease and the Parkinson's plus syndromes. And idiopathic Parkinson's disease, as we said, has many genetic subtypes and variations, but Parkinson's plus syndromes are multiple different diseases, including multiple systems atrophy, MSA, PSP, progressive supranuclear palsy, corticobasal ganglionic degeneration, and many others. And then you have the secondary Parkinsonisms, vascular, drug-induced infections, trauma. When the patient comes to your office, you don't know which of all of these they have, right? They come with symptoms that look like Parkinson's disease. So our first job is to figure out which of these the patient is actually having, because all Parkinsonism patients must be assessed for curable or treatable causes of Parkinsonism, including, you know, some lab work and imaging testing to reasonably rule out treatable conditions. So all Parkinson patients and all Parkinsonism patients share these three features of bradykinesia, rigidity, and about 60% of them have resting tremor. But Parkinson's plus syndromes then have something else. That's why we call them plus. How clever. And we must differentiate them because the life expectancy for Parkinson's is basically normal. But for Parkinson's plus, the prognosis is different, is much poorer. So we must know they don't respond to oral treatments or deep brain stimulation surgeries. So we must make that differentiation so that the patients can plan and we can work with them accordingly. So if you have ataxia, open-motor neuron signs, severe dysautonomia, then we start thinking about another type of disease like multiple systems atrophy. And that is an alpha-synucleinopathy, just like Parkinson's, but the accumulation of the alpha-synuclein is in glia rather than in neurons. And if you have abnormal extraocular movements, then we think about progressive supranuclear palsy. And if you have a hemi-syndrome of hemidystonia and apraxia and other symptoms, then we think of corticobasal ganglionic degeneration and other diseases. And these two are tauopathies, accumulation of tau, another protein. And imaging can help us dramatically, and we're learning a lot about the imaging of these diseases. And you can see here how in PSP we have what we call the penguin sign or hummingbird sign. We have the Mickey Mouse ears in the midbrain. In corticobasal syndrome, we have significant asymmetry between the two hemispheres, and in MSA, we have multiple signs, including the lateral linear T2 hyperintensity in the putamen due to the atrophy there, and the hot cross bone sign, and pontine atrophy, cerebellar atrophy, and many more. SPECT dopamine transporter imaging is also very useful in patients with Parkinson's disease and Parkinsonian disorders, because it helps us differentiate between the degenerative Parkinsonian syndromes and the non-degenerative causes. And this is sort of the interpretation of the results of the DAT scan. So, if it's positive, we're thinking about Parkinson's disease and any of these degenerative diseases that cause striatonigral degeneration. But if it's negative, then we're thinking more of dopamine responsive dystonias and vascular Parkinsonism, medication-induced Parkinsonism, which is one of the most important uses of this particular technology, essential tremor, functional movement disorders, and many other conditions. Should patients with Parkinson's disease get a biopsy? Well, the short answer to that is many patients will need to consider it now, but not a biopsy where you're thinking this is different. We're not trying to get a biopsy in the brain anymore. Although that's where alpha-synuclein is going to be, right? The red dots here is alpha-synuclein inside the neurons. But remember that we also have neurons in other places in the body. In fact, we have more neurons in the abdomen than we have in the brain. So accumulation of abnormal phosphorylated alpha-synuclein is associated with 5 different disorders: Parkinson's disease, dementia of Lewy bodies, multiple systems atrophy, pure autonomic failure, and REM sleep behavior disorder. So if we find this alpha-synuclein accumulated in somewhere, then we need to be thinking about these conditions. So the search for ways of confirming this presence of phosphorylated alpha-synuclein has been ongoing for a long time. And, we have used multiple options like brain imaging, including functional imaging is not specific. The use of CSF, from a lumbar puncture and measuring phos-seeing is not sensitive. Colonic and submandibular, okay. Okay. Colonic or submandibular gland biopsy is harder to do than skin, for sure. And this is a TrueCut biopsy of the submandibular gland that was has been described because you can find alpha-synuclein there as well. So these are options that we have currently on trying to find alpha-synuclein and helping us know if the Parkinsonism that the patient has is caused by an alpha-synucleinopathy or not. But now we have basically a very, very simple option, and is the skin biopsies, which allow the visualization of the nerves. And these nerves have been demonstrated to contain phosphorylated sin in Parkinson patients and accurately diagnose Parkinson's disease with a more than 95% sensitivity and a specificity higher than 99%. So this is a great option that has been around for a while, and we need to be expanding its use because it's so simple to do. It helps us answer a very important question: is there alpha-synuclein in the nerves of this patient? And then more research is being done that is helping us understand if differentiate between Parkinson's disease and other PD plus syndromes. So in summary for this question of how do we diagnose Parkinson's disease, we used to just examine the patient and say, you've got Parkinson's. Now it's different. We must rule out treatable conditions. Parkinson's disease patients need to be differentiated from PD plus syndromes. And we continue to do that through a comprehensive history taking and a thorough neurological exam, yes. But we also have to do lab work on all patients and an MRI of the brain and spine in most patients, consider a DAT scan in some patients, and then the skin biopsy, skin nerve biopsy is going to have a growing role in the future. Next question that we wanted to talk about is, why do we say that Parkinson's care must be comprehensive and multidisciplinary? Well, the short answer to that is basically, well, because Parkinson's care has become very complex, and because Parkinson's disease is a multi-systems disease. So, a single person cannot care for Parkinson's anymore. The management team starts, of course, with the patient in the center, and we have a lot of people: occupational therapy, speech therapy, physical therapy, the family and the caregivers, the community, and the physicians, and then the physicians who are leading the team. We only have about 4,000 or 5,000 movement disorder specialists in the United States. So we cannot care for all patients with Parkinson's disease. So the care for Parkinson's is handled by neurologists, by primary care physicians, internal medicine, and that is how things are done currently. Levodopa is the most effective treatment in Parkinson's disease, hands down, but we have many, many more options, and I'm going to just show you a few in historical order of the medications that have been developed over the years. And each year there are a few more. Each of these medications has a different mechanism of action, has a different side effect profile, has a different place in the treatment of patients with Parkinson's disease. And it is critical to know which of these medications I can use for my patient for the particular symptom that the patient is having, because each of these drugs is not for every patient. Every patient cannot get all of the drugs at the same time. So understanding, okay, what's, all of them is extremely complex. Learning about them, having enough experience for, with each of them is hard, is a lot. These medications don't come without a price. They have side effects. The most common one is dyskinesias, motor fluctuations, and other complications like loss of appetite and difficulty sleeping or too much sleepiness, lightheadedness upon standing, including syncope, loss of control issues, OCD-like behaviors, hallucinations, as I discussed, and somnolence. So it's not easy. A lot of people ask me, Diego, give me the short answer. What do you do? What's the fix? And I wish I could give you a short answer. I'm gonna give you some general thoughts, and it is a generalization that does not do justice to the complexity of the disease for sure. But I'm gonna start with some general principles of what do we do with the presence of off when the patients are not feeling well continuously. The first is to always consider and treat the non-motor symptoms. That's important, as we discussed, because they drive quality of life. The second is to always treat the patient's most bothersome symptom, not yours. You might see the patient shaking like a leaf, but that might not be the problem that is driving their their quality of life. For them, it might be a different problem, like walking difficulty. So you must address the problem that they are most bothered about. Always do general management of Parkinson's before trying pharmacological treatment for each of the problems that you're dealing with. So exercise, physical, occupational, and speech therapy, skincare. Remember that patients with Parkinson's disease are at a much higher risk for melanoma. The patients will not die from Parkinson's, but they can die from melanoma. So you must make sure that this is taken care of. And a lot of people don't know about this association. And then think about social determinants of health for sure. In the presence of off, always consider to do on-demand therapies and maintenance treatment changes, because that is the best course of action. And introduce the concept of surgery early. The patients need to hear about options because it's not you making the decision, it's them. So they need to be educated properly about what their options are. What are the first drugs to start? This is another question that I'm always asked. And again, this is a horrible oversimplification. But if you're older than 60, I would think levodopa is the first choice. If you're younger than 60 and strong, mild symptoms, rasagiline and a dopamine agonist are options. If you're younger than 60 and strong and you have moderate symptoms, then levodopa is a choice and dopamine agonists as well. But if you're young and strong and you have severe symptoms, then levodopa is the first drug to start, no matter what, no matter how young you are. I have patients who are 20 and are using levodopa. I think that we have been worrying too much about the early use of levodopa for many years, and I don't believe that that is granted. In the presence of off, if the off time between doses is more than an hour, then I usually add one more dose of levodopa, for example, going from TID to QID, or exchange the patient, from Sinemet, carbidopa levodopa to Rytary. If the off time between doses is less than 1 hour, then we can add any of these options: entacapone, rasagiline, safinamide, opicapone, estradinophile, and then as needed options, the on-demand treatment. If symptoms are mild, I usually favor Inbrija. If symptoms are beyond mild, I usually favor apomorphing sublingual. So what do we mean by this on and off? Well, when the medications are working, we call it on. And when the medications are not working, we call it off, right? When the symptoms are back, we call it off. So at the beginning of the disease, the patients take their medications and they're on all the time. But as the disease progresses, then they start developing this off periods in between doses, and sometimes they develop the periods of side effects, dyskinesias as well at the peak doses and some other times. So basically, they are either on, off, or over with their disease and their treatment. Off episodes are highly prevalent. Approximately 50% of people with Parkinson's disease develop off as early as 2 to 5 years, in the majority by 10 years. In a survey by the Michael J. Fox Foundation with 3,000 patients, 92% of patients on that survey had at least one off episode per day. 20% experience 4 or more off episodes per day, and 64% of patients spent 2 or more hours in the off state. Now, this, I think, is a calamity. I mean, think about this for a second. We have more than 30 drugs. We have, surgeries. We have so many options available in the market, and yet our patients are undertreated, suffering from the disease. And the question is, what are we doing to fix all of these symptoms? So how can we detect, excuse me, how can we detect these off states better, right? I mean, clearly we must. So how can we detect these off states? Well, we can use the patient report during the visit. We can, have the physicians detect these off states during the visit. We can use surveys and scales. We can use patient diaries. We can use wearable devices. Let me tell you this, with the current environment that physicians live in, where we are being asked to see a patient in 15 minutes. I'm not sure how we can do all of the things that we must do for a patient with, with a complex disease like this. So let's think about our options. The patient reporting is not accurate. That is clear and well known. Physician detection is definitely not perfect, about 50%. Other scales are not as good either. So new wearable devices are more accurate on detecting off. And therefore, I really prefer this choice. So continuous objective measurement devices are having such a slow practice incorporation, and I don't understand why. Well, I do, but we must change these. They are more sensitive than patients and physicians, and they are more accurate at measuring tremor and akinesia fluctuations. On this paper that we did, we just published, evaluating the morning bradykinesia in patients with Parkinson's disease in the United States. We studied more than 3,000 patients using the PKG, the personal kinetograph, which is a device that is able to measure most Parkinson's signs and symptoms, and it's just like a little watch that the patients carry day in and day out. Using that device in more than 3,000 patients, we detected morning bradykinesia in 85% of US individuals. And after this is the worst piece of the data, is that after the first carbidopa levodopa dose, so after they treated their disease in the morning, still 64% of them had continued morning bradykinesia. Many didn't even know, because they had taken their medication, they had started their day, they had not even realized that the medication was not working fully or properly. So this is tragic in my eyes. Parkinson's disease also carries a great risk for another movement disorder called dystonia. Dystonia is excessive muscle contraction that can cause tremors and can cause abnormal postures. And it can be extremely disabling to our patients with Parkinson's disease. And what causes dystonia in Parkinson's is the disease itself, but it's also, it can also be a medication side effect. We have multiple treatment options for dystonia. It's extremely treatable condition: physical therapy and occupational therapy, oral medications, and there are many options. Many of the drugs that we use for Parkinson's can help with some of the dystonia symptoms, unless the dystonia is medication-induced. Botulinum toxin injections are extremely helpful for dystonia and are the mainstay of the treatment. And then surgery can be very beneficial. And I was just speaking earlier today with Dr. Sporer about how, you know, we do so much for dystonia patients with deep brain stimulation, in particular in Parkinson's disease. Botulinum toxin injections for patients with blepharospasm can be life-saving. Blepharospasm is a dystonia of the eyes, of the orbicularis oculi. And what the patients get is that they cannot open their eyes, and they're trying, but they cannot. And you can see on the right side, the patient is really trying to open the eyes on week 1 and 2 after Botox injections. And then on the right side of the screen, you see weeks 6 and 7 after the medication actually started to work. So this can save the patients from being functionally blind, which is you know, a dramatic improvement of their quality of life. Patients with Parkinson's disease can have also severe anterocolis, a neck dystonia. Look at these extreme postures. This is an extreme case in particular, but you can help the patients with botulinum toxin injections, and this is the after injection picture. You also can have camtocormia, which is the bending of the entire spine. So here, notice that the neck is actually aligned properly with the spine, so there is no anterocolis, there is no change in the neck, but what you see is a bending of the spine. I'm sure that you're seeing how dramatically this can affect the patient's quality of life. But with injections with botulinum toxin, you can actually improve these easily. Autonomic dysfunction in Parkinson's disease is widespread, extremely significant. It drives quality of life, and it's a very, very important situation to get a hold of. It affects the cardiovascular system, causing orthostatic hypotension, gastrointestinal disturbances, urinary impairment, sexual dysfunction, and sweating. So we must address each of these problems if we hope to help the patient's quality of life. In neurogenic orthostatic hypotension, which is this change in the blood pressure upon changes on posture, is present in about 30 to 40% of people with Parkinson's disease. And it can be made worse by the use of the medications to fix Parkinson's. So imagine this, you have this which is caused by the disease, and the drugs that we use to fix the disease make it worse. There are many symptoms of this condition, and some of the patients don't present with just the lightheadedness. They can present with cognitive impairment, they can present with changes in their gait, they can present with falling, they can present with many symptoms, and it is terribly under-recognized and therefore under-treated. The standard of care is early detection, recognition of the uncommon signs of neurogenic orthostatic hypotension. The use of autonomic lab testing is key for the diagnosis, and of course the use of appropriate medications. But you know, we cannot fix it if we cannot diagnose it. So this is why we must include this multidisciplinary team to be able to help diagnose this condition. So I hope I have been able to answer this particular question as to why we must include a multidisciplinary comprehensive team so that we can care for this extremely complex disease with new diagnostics, many innovative devices, many new drugs, specialty procedures and surgeries. And for a disease that is multi-system with dysautonomia, psychiatric, gastrointestinal, genitourinary symptoms. We wanted to talk about then what are the most important innovations in PD care, and there are many. I really was fighting to decide, okay, what do I include here? And I'm in general a very optimistic guy. I'm always staying on the bright side, and there are many bright ideas about this condition. So let's talk about some of them. One, is the recognition that carbidopa-levodopa absorption is extremely variable because of the presence of gastroparesis. So one of the GI symptoms from dysautonomia is that the stomach doesn't move, the gastroparesis. And here in this picture, you can see during endoscopy, a peel of Sinemet sitting in the stomach after an hour and a half of the patient taking the drug. So, but the peel is still sitting in the stomach. Sinemet is not absorbed in the stomach. It has to be absorbed in the small bowel. So if the drug doesn't pass the stomach, you're not getting the benefit. And in here on the right side, you can see the oral carbidopa-levodopa absorption in a number of PD patients. Each of these lines is a PD patient. And you can see that, for example, this patient in blue had an immediate absorption within 10 minutes and a peak within 15 minutes. But this particular patient in yellow, for example, started to have absorption, and peaking at about 60 minutes. And this patient here in purple didn't have any absorption whatsoever for 90 minutes. And then all of a sudden started to have absorption, and the peak was at 120 minutes. The variability between patients is incredible. And the variability inside the same patient is also extremely high. So imagine if you cannot, the most important treatment for Parkinson's is levodopa, and most of the drugs that we give are given orally. But if you as a patient cannot rely on the onset of this treatment, how much can that affect your quality of life, your planning of your day, right? It's like, well, I take it now, it should be starting to work in the next whatever, but then it doesn't, right? So this drives quality of life dramatically. So we must address that with our patients. And that's why I believe that we must empower them with the use of on-demand therapy options. And we have now 3 options. We have levodopa inhaled in the form of Inbrija, and we also have sublingual apomorphing. And I have consulted for both of these companies. And we have a third option, which is apomorphing injectables, which has been around for many years. These drugs are powerful, they're effective. They start working within 10 to 15 minutes. With a peak benefit within 30 to 60 minutes. They can use them up to 5 times a day, and they bypass the GI tract. So it can be extremely helpful to salvage those patients who are in the off state so that they don't have to suffer those off states. So this is important to incorporate. Another great innovation, I think, in the Parkinson's care is estradinophile. Estradinophile is the first adenosine A2A receptor antagonist that has been used in Parkinson's disease. Why is this important? Adenosine A2 receptor stimulation in the indirect pathway reduces the motor activity. It works when you stimulate these receptors, it works like a brake pedal on your movements. And then dopamine does the opposite, right? So you stimulate dopamine receptors, it actually increases motor activity. It works like the accelerator pedal. But in Parkinson's disease, the A2A receptors are increased, while the dopamine receptors are decreased. So basically, you are not only not pushing on the accelerator, but you are also pushing on the brakes. So these two issues are making the patients move slower. So the use of estradinophile has been proven to improve symptoms in Parkinson's disease. And the good news, the importance of this is that this is a drug that is not addressing the dopamine side. It's finally addressing something that we had never been able to address before, which is the adenosine side in Parkinson's care. It's given once daily, and it has some side effects, as I have written there, but is in general well tolerated. The next advancement for sure is PKG and the continuous objective monitoring. This is one of the 8 pages of data that I get from each patient. And I'm going to show you an example of a dose failure. This patient was telling me, Doc, I get so sleepy after my lunch. And I said, well, me too. But he said, no, but it's weird, but it's too much. And I said, okay, let's look at it. And here in the bottom, you can see in black each day, you can see tremor. The red lines are the doses of the medication, okay? So there is tremor around the doses, and then when the medication kicks in, there is no tremor. That's great. But then after 2 p.m., look at what happens. There is a lot of tremor after 2 p.m. So it's like, that's interesting. This dose doesn't seem to be working. Let's look at the charts. Here is the measurement of bradykinesia. And as you going up means is less bradykinesia here. So you take your dose, the bradykinesia goes away and then comes back. You take your dose, bradykinesia goes away and then comes back. And you take the dose at 2 p.m. and bradykinesia, nothing happens to bradykinesia. So with PKG, I was able to prove that the patient was having a dose failure at 2 p.m., some days, and I was able to address the patient's symptoms. So it can be extremely helpful. And then with the motor fluctuations in Parkinson's disease, which are many different subtypes, we need to consider advanced options, including surgery, when you have motor fluctuations or dyskinesias for sure. And surgeries continue to be one of the most important innovations that we have. They help you stay on longer with less dyskinesias and less medication side effects. So what are the surgical options? We have Duopa pump, which delivers levodopa continuously beyond the stomach into the jejunum. And by doing that, into the small bowel, then we're avoiding the whole issue of the gastroparesis, which is great. It's a continuous infusion, and it helps many of our patients. And we have seen a reduction of off time that is very significant with the use of this medication. And the side effect profile is very acceptable. Most of the side effects, as you can see in this slide, occur during the first week of the insertion, and after that, the side effect numbers go down significantly. And another important innovation is deep brain stimulation, as you heard from Dr. Sporer before, is a great choice for Parkinson's disease. And we have an extensive evaluation protocol at our center that starts with the movement disorder evaluation and a multidisciplinary team discussion, including neuropsychologists, neurosurgery, and the movement team together, thinking about the candidacy for each of the patients. And after that, they come back for programming. But the risks of the procedure are listed here, stroke, bleeding, basically, and infections are important to consider, and we discussed that with the patients, including death. But the benefits outweigh the risk for many of the patients. And as you can see here, this patient is extremely happy in the OR, having absolutely no tremor. I'm sure you can see no tremor here right now, right? All right. Then we just talked about FOS. What's the FOS about FOS in Parkinson's disease? Well, it's now incisional, but it's lesional. We have to think about single site implications. We don't have long-term data. There is a relative high complication rate in comparison with what we get from DBS currently, but it definitely has a place in the care of Parkinson's patients, and we're excited to have that new technology. So with so many treatment options, patients should not have to adapt to the disease. Treatments and physicians must adapt to the patient's needs to maintain dignity, lifestyle, and quality of life intact. We have so many options. For example, an important innovation now is the detection for the cardiac dysautonomia in Parkinson's disease using continuous non-invasive arterial pressure monitors, which are able to pick things up when the autonomic lab fails to do it. So I think that the future is bright in Parkinson's care. We have so many innovations and so much help. The next question that we were going to review is, what can we do right here, right now, to enhance the patient experience, the Parkinson's disease experience? And I asked a question earlier during my visit, which is, how many unique patients Baptist Health has inside the system? And that's the number that I was given, 700,000 people. If we use this number to calculate the minimum expected number of Parkinsonian patients, the minimum expected number would be 14,500 patients with Parkinsonism, 7,000 or so of Parkinson's disease, and 7,000 or so of PD+ syndromes. So if we calculate the number of visits that this would need to provide proper care for these patients, including dystonia visits, deep brain stimulation visits, and regular Parkinson's care, we're talking about more than 1,600 visits per week to care for the patients that are already inside our system with Parkinson's disease. So I think that the first thing that we need to do is to recognize that we are doing a poor job inside every system in the United States, for the care that we provide for Parkinson's. We must recognize that we're failing so that we can do better, and we can do what we must do, what we went into medicine to do, which is to help our patients. So I'm going to finish my chat to summarize some of the thoughts. We must provide a patient-centered, comprehensive, multidisciplinary care in Parkinson's disease. Neuropsychology, physical therapy, occupational, speech, nutrition is so important. We did a study, collaboration with Harvard, where we found 35% of our patients have nutritional deficiencies. Remember, GI problems. We must provide the collaboration of many specialists in Parkinson's disease, neurologists, movement disorder experts, neurosurgeons, psychiatrists, primary care physicians, radiologists, urologists. We need advanced imaging, MRI, DAT scans, cardiac, adrenergic imaging. We need an autonomic lab. Continual objective monitoring has to be part of what we do. Alpha-Synuclein skin nerve biopsy, deep brain stimulation program, all targets, all systems are key for comprehensive Parkinson's care. a Duopa pump program has a place, so that we can provide the best care for our patients. Focus ultrasound procedure program, genetic counseling for the 15% of patients who have a genetic basis for this disease. Patient and caregiver education and advocacy is key, and I'm extremely passionate about that. Local training in Parkinson's disease for the next generation of healthcare workers. We movement disorder experts cannot do it all, for sure. We must train everybody in detecting and helping us with this disease. And then for sure, clinical trial research availability has to be expanded so that our patients can have access to that. And also we can enhance our future and find a cure for this disease. And with that, I'm going to finish and I'm open for questions. Thank you so much for inviting me to speak. It has been a real honor. Thank you.
Any questions?
Any questions?
Yes, hi, Dr. Torres, it's Ron Tolchin. Great lecture, great talk. Appreciated all your insight into this very significant disease. Wanted to ask you, you brought up a slide earlier on the boxing program you have, and I do feel as a physiatrist that sending people to general physical therapy is not always the answer for these patients. You need a more comprehensive program. The question is, there are not as many of them, around. They become costly, and I wanted to see if you've been able to navigate the system in such a way that these patients can have several hours, several days a week of therapy services and get it covered in some way.
Yeah. Well, that's a great comment. We must enhance physical activity on every patient, and it's physical activity, right? And there are studies on yoga, there are studies on Pilates, there are studies on dancing, tango. There are studies on salsa. There are, all of the studies are showing that the more active the patients are, the better their quality of life. So there is nothing magical about it. We must enhance their physical activity overall. And sometimes, what they need really is a more guided approach. And there are so many options in the community that are even free for the patients. So understanding those options and providing advocacy for the patients is really key.
I have a question. Is there no way to?
Thank you.
Yes.
Hi, this is Kevin Abrams, Neuroradiology. Outstanding talk. The question I have here is I wasn't aware about this biopsy technique that's so sensitive and specific. So I guess the question is, why is it not used more? I mean, we do a lot of DAT scans, which a lot of times can't even get it approved by insurance. It's not as specific. It sounds like the biopsy sounds even better. Is there a reason it's not being done more?
Yeah, that's please answer the question for me. I would love to know why. I don't understand. There is significant research about it. Of course, it's a new thing, and every change, finds some resistance. Medicare covers it, but many people don't even know that it exists, right? So until we don't expand its use, it will continue to be so. I believe that we just have to fight the fight and continue to expand education and knowledge about it so that we can provide the best possible care.
And which physicians are doing the biopsies? So if you want to refer somebody, who are you going to refer them to do those biopsies?
Yeah, so anybody, who this is a punch biopsy, a skin punch biopsy. So it is best it has to be shipped immediately back to the lab that is going to be reviewing it. So we do it in the movement disorder clinic. And in neurology, usually the experts that do skin biopsy are the neuromuscular experts because they do a lot of small fiber diseases, or the movement disorder experts who are trained in skin biopsy. So at our center, I have 9 movement disorder experts, and all of them are, in the process of being certified to do the skin biopsies. So currently I'm the one that is doing them.
Great, thank you, excellent.
Yes, thank you.
This is Felipe, a fantastic presentation as well. I agree with the rest of my colleagues. It was great having you and meeting you yesterday as well. And regarding the skin biopsy, I agree. I mean, this is, this would be very helpful if we had more access to it. You would use the interpretation of the skin biopsy very similar to the interpretation of the DAT scan, meaning it wouldn't tell you or differentiate between any Parkinson's plus syndrome, but just generally Parkinson's disease or syndrome versus some mimics. Would that be how you would be looking at the interpretation of those biopsy results?
So you see a patient, thank you, Felipe. You see a patient with Parkinsonism, right? So the question is which type? If you find alpha-synuclein, now you know in the biopsy, now you know that it is an alpha-synucleinopathy. So now you have shrunk the differential diagnosis to just alpha-synucleinopathies, and you have only 5, right? Out of those 5, there are only, a handful, right? So there's already very few, but there are only 3 that cause Parkinsonism. So, you have been able to really reduce your options by doing that. So nothing is perfect, but the specificity in the right patient was extremely high in some of the studies. So it's just one more tool in our, way to the diagnosis of Parkinson's. Yes, thank you for that question. Great question. And I see a lot of questions in the chat as well. Let's see. But please, if there are more questions, go ahead.
Thank you so much, Dr. Torres. This is Justin Sporer. That was an awesome, fantastic talk, very thorough. My question is the duopa. Who does those, and are the patients, how open are they to that when you mention that procedure to them?
Yeah, great question. Thanks, Justin. The duopa procedure is done by trained GI specialists or interventional radiologists. And it is, patients have significant resistance to that particular procedure because they have to now have a tube hanging out of their abdomen continuously and deal every morning with the exchange of the cassettes to be able to get the medication. There are a number of patients who cannot qualify, they just cannot get deep brain stimulation surgery, and they're having significant motor fluctuations. And they definitely will consider duopa. And then there are patients who are very scared of brain surgery, and they would prefer for sure that route. Now with the use of ultrasound, the use of duopa is probably going to go down even further, but that's another option. I think we're running out of time, I'm being told, so let me have the boss back here with you.
Well, thank you, Dr. Torres. That was a very comprehensive discussion about the current status of treatment of Parkinson's. I think we'd all agree. Really thank Dr. Torres for coming. He's going off to a national meeting to present again on a slightly different topic today, but we thank him for making the trip. Thank you, and have a good day, everybody, and a good weekend.